Students, welcome to this explainer. Today, we're going to build an absolutely crystal clear, rock-solid foundation on the clinical approach to anemia. We're starting right from the bone marrow factory itself and taking it all the way to the clinical wards. If you want to crack your exams and actually shine during your clinical rotations, you need to pay close attention to this one. Let's get started. Okay, so here's our quick game plan. We'll zip through the core definitions and hematopoiesis basics, map out the RBC maturation journey, make sense of those tricky reticulocyte counts, tackle the master clinical approach, and then wrap things up with some high-yield bone marrow basics. Starting off with our first section, let's get our basic definitions perfectly straight. Listen carefully, you must memorize these WHO cutoffs. These are direct, straightforward MCQ hits, guys. We define anemia based strictly on hemoglobin levels. Less than 13 grams per deciliter for adult males, less than 12 for females, less than 11 for pregnant women, and less than 10 for our CKD, chronic kidney disease patients. Just fix these baseline numbers in your brain right now. Now, take a look at this beautiful flowchart. This right here is the entire factory layout of blood cell production, hemopoiesis. Every single blood cell you see in the periphery traces its ancestry back to one single origin in the bone marrow. Layering this conceptually, we start at the very top with the pluripotent stem cell. That branches into the common myeloid progenitor, then down to the blood-forming unit erythroid, and finally, we arrive at the proerythroblast. Now listen, here is the high-yield funda. This final step strictly requires two things, erythropoietin from the kidneys and iron. Without EPO and iron, the factory line literally shuts down. Concept clear? Okay, moving right along, let's see what happens to that cell next. So now that we have our proerythroblast, let's observe the assembly line in action. Notice the progressive morphological changes as you go from top to bottom. See how the cell changes in its size, its overall color, and its internal structure as it preps to enter the peripheral blood? It's a massive transformation. I've simplified all that into this high-yield table for you. Notice how the cytoplasm shifts from a basophilic blue to a nice reddish color. Why does it happen? Simply because it is packing itself with hemoglobin. At the exact same time, the nucleus becomes super dense and pycnotic until it is completely expelled. The mature RBC literally sacrifices its own nucleus just so it can carry maximum oxygen for your body. Pretty beautiful physiological adaptation, right? All right, shifting gears a bit, let's talk about the factory's final output. Once that cell ejects its nucleus, it officially becomes a reticulocyte. And this particular note highlights an absolutely crucial testing concept. You see, reticulocytes still have a tiny bit of RNA left over in their cytoplasm, which gives them this slight bluish tinge. Now, this is a classic 5-star MCQ point, mark my words. Reticulocytes require supravital stains like brilliant cressy blue or new methylene blue to actually detect that leftover RNA. Your standard Romanowski stain, it simply will not detect them. It'll just show polychromasia. So if the examiner asks how to visualize a retic, your reflex answer has to be supravital stain. Are you with me? But wait, a raw retic count can actually trick you. To know what's really going on, we have to calculate the corrected reticulocyte count, or CRC. You do this by multiplying the raw count by the patient's hemoglobin divided by the normal desired hemoglobin. And we don't stop there, students. You must divide that CRC by a maturation factor of 2 to get the reticulocyte production index, the RPI. This accounts for those prematurely released cells. This RPI, this is your ultimate golden number. So, how exactly do we use that golden number? Let's bring it straight to the clinics. Using all the physiology we just built up, we finally arrive at the master clinical algorithm. This is the definitive diagnostic flowchart you are going to use every single day in the wards. If you master this, no case of anemia will ever confuse you again. How do we use the RPI here? Well, single lineage anemias are divided purely based on this value. An RPI of less than 2.5 means the factory is failing. It is a hypoproliferative anemia. But an RPI greater than 2.5, that means the factory is working overtime. It's hyperproliferative. The marrow is perfectly fine, but the cells are being destroyed out in the periphery because of hemolysis, or maybe they are being lost to active bleeding. Now, if it's hypoproliferative, meaning that RPI is less than 2.5, we immediately jump to the MCV. A microcytic or normocytic MCV points straight to factory shortages, things like iron deficiency, chronic disease, sideroblastic anemia, or thalassemia trait. On the flip side, a macrocytic MCV greater than 100 points straight to megaloblastic anemia. Why? Because the red cells are lagging in their nuclear maturation due to B12 or folate deficiency, all while the cytoplasm just keeps on growing. Makes perfect sense, right? All right, let's wrap this session up with some quick, high-yield facts about the bone marrow itself. You've got to remember these golden rules for marrow assessment. First, the cellularity percentage is roughly 100 minus the patient's age. So a 50-year-old should naturally have about 50% cells and 50% fat in the marrow. Next, the normal myeloid to erythrocyte ratio, the ME ratio, is exactly 3:1, simply because WBCs have a much shorter lifespan, so you need to produce more of them. And lastly, in marrow failure syndromes like aplastic anemia, those active hematopoietic cells are basically completely replaced by fat. I'm going to leave you with a quick clinical scenario to solve. A 50-year-old patient presents to you with severe anemia. Their bone marrow biopsy comes back showing only 10% cellularity, and it's mostly filled with fat. What primary diagnosis should you immediately suspect? Think about this, apply the step-by-step framework we just discussed today, and master your diagnostics. Thanks for joining this explainer. Keep studying hard and definitely keep revising these